I am going to discuss today a very interesting and important topic, that is abnormal uterine bleeding. Save the uterus. Um, and I bring greetings from Omega Hospitals Nagpur, along with Nagpur OBGYN Society, where I have worked as a president. My special thanks to Nima for giving me this wonderful opportunity, and of course, I must thank and mention here that Archana is I know her since last I guess 15 years, and I've seen her working and growing. She is a sincere and dedicated, hardworking clinician, and I'm very fortunate to have you, Archana, as my. As you have worked with me, I am really fortunate to have you with me. Then we have Dr. Kamini, Dr. Priyanka, Dr. Vishnu, Dr. Rajesh, and Dr. Jagruti. I must thank everybody for giving me this opportunity. Now I would start with the topic which I'm supposed to discuss today, that is save the uterus, and why we I have selected this topic, or why I have chosen this topic, because there is a reason behind it. There was an LAQ, ज्याला आपण मराठीमध्ये लक्षवेधी सूचना म्हणतो, in a Maharashtra Legislative Assembly on hysterectomies done in Beed district of
ये डिस्ट्रिक्ट
Maharashtra.
पाहिजे चहा
अ,
बिस्किट
बीड जिल्ह्यामध्ये ऊस तोडणीसाठी जाणाऱ्या महिलांना मोठ्या प्रमाणावर हिस्टेरेक्टॉमी करण्यात येत असे. आणि द प्रॉब्लेम वॉज की ज्या बायकांना मुलं झाले त्यांनी कामावर व्यवस्थित हजर राहावं म्हणून they used to remove the uterus of all the women working in the fields, so that they don't take leave for the menstrual reasons. And this is really horrible. And there was a LAQ, then the inquiry was committee was there, and then this inquiry committee, they decided to have SOPs and standard operating procedure for doing hysterectomy in any patient with abnormal bleeding. And now the government has come up with the notification that you are supposed to notify government and also justify if you are doing hysterectomy in a woman who is less than 40 years of age. So this is a very important point, my dear friends, and this is an eye opener for all of us, that we should keep this in mind, that whenever a patient comes to you, if she is less than 40 years of age and if you are planning hysterectomy in that patient, you have to notify to the government and explain to the government that why at such a young age you are doing hysterectomy. So hysterectomy should be done very, very carefully and only when it is really required. Now we will start with the basics of abnormal uterine bleeding. When we were in college, during our college days, there were definitions which we used to mug up, like menorrhagia, metrorrhagia, oligomenorrhea, hypomenorrhea, polymenorrhea, DUB, epimenorrhea, etc. Menorrhagia means prolonged bleeding. Metrorrhagia means intermenstrual bleeding. Breakthrough bleeding, where the bleeding is there in between the menses. Oligomenorrhea is scanty menses. Hypomenorrhea is where the flow is diminished and the cycles are short. And polymenorrhea is frequent menses. But now, the FIGO has said that this nomenclature is no more used in the definition and the diagnosis of abnormal uterine bleeding. And this is these are the terminologies which are now abandoned, rejected, and discarded. So what they say is nowadays it is labeled as heavy menstrual bleeding. I remember during our college days the nomenclature was FUH, that is functional uterine hemorrhage. Then that nomenclature changed to DUB, that is dysfunctional uterine hemorrhage. So functional become dysfunctional uterine bleeding. Then it was changed to AUB, means abnormal uterine bleeding, and now it is called as heavy menstrual bleeding. See how the nomenclature is changing and the guidelines are changing. And now, for any heavy menstrual bleeding, the patient coming to you with heavy menstrual bleeding, there is a palm coin classification which is to be kept in mind. So, what is this palm coin classification? We have palm, means P for polyp, A for adenomyosis, L for leiomyoma, and M for malignancy. So these are the structural defects which can lead to bleeding. And then we have coin, where C is for coagulopathy, O means ovulatory dysfunction, E means endometrial cause, I is iatrogenic cause, and N is non-defined or cause, or where the cause is not known. That means all the coin classification goes into non-structural causes, and the palm classification goes into the structural causes. So it is very simple and clear to all of you. So this is what is palm coin classification. Now, what is the impact of heavy menstrual bleeding on the quality of life? It is the quality of life which is important for every woman. She should be able to work properly, she should be able to work efficiently, there should not be any anxiety, there should be no depression, there should be no decrease in the work productivity, there should be no anemia, patient should not have discomfort, patient should not have pain, and there should be no negative impact on the sexual relationship. So overall, the quality of life is decreased whenever the patient has got abnormal uterine bleeding. Now it has been found that in 60% of women where there is a problem of bleeding, they end up in hysterectomies.
आगे फोन
And
करते तुला
if you just look at the statistics say that one third of the hysterectomies are not necessary. That means you can avoid so many number of hysterectomies, which is possible if you actually do the things properly. The incidence is very high, and almost 30%, and 50% of these patients are of perimenopausal age group. So around 45 years is the age group where you get maximum problems of abnormal uterine bleeding. And many patients with postmenopausal bleeding also will come to you. Now, this postmenopausal bleeding needs a special mention
अरे
because
तेरे वायर
whenever
नहीं लिए
I think
इसे
Archana,
ले बा
somebody is speaking in the background, so maybe you can ask everybody to mute themselves so that the others will be able to listen to my talk properly. So I think
My
somebody is,
sincere request to everyone,
yeah,
kindly mute yourself. It is very disturbing for the speaker. Kindly
yeah,
mute yourself.
yeah, yeah, it's okay. So postmenopausal bleeding needs a special mention because whenever the bleeding is after menopause, whenever the bleeding is after menopause, the cause is many times benign. सो यू शुड नॉट गेट पैनिक कि पेशेंट 60 साल की है या 55 ईयर्स की है और उसको ब्लीडिंग हो रहा है, इसका मतलब मैलिग्नेंसी है, ऐसा सोचने की जरूरत नहीं है. Because many times it is atrophy of the vagina or a small polyp which can be a cause of bleeding. But at the same time, you should remember that your role as a physician becomes more important because the chances of malignancy in this age group are high. So your job is to rule out malignancy so that the patient knows that there is no cancer as a cause of bleeding, and this is what is important in this age group. So what is important, you should actually do proper investigations after doing examination. TVS is nowadays gold standard for the diagnosis. TVS is always done first after doing proper examination and taking proper history. Along with TVS examination, you may go for MRI because MRI is becoming more and more important nowadays because MRI is one investigation which can actually give you a clear idea, especially in pelvic problems. So in pelvic problems, MRI is an important investigation. Hysteroscopy. Hysteroscopy to see the cavity from inside and to treat the problem immediately in the same setting is also becoming important. And finally, you can take a biopsy so that you are confirmed or you are sure that there is no malignancy or the malignancy is ruled out. Now, what is important is you should offer something different. If you offer something different to your patient, the patient will come to you. You don't have to go to the patients. So, what is important is you should give them options of saving the uterus because uterus निकालने वाले तो बहुत है. यूट्रस निकालना बहुत आसान है, लेकिन यूट्रस को बचा के रखना ये एक चैलेंज है और ये चैलेंज हम सब ने एक्सेप्ट करना चाहिए. एंड वी हैव टू सी टू इट दैट हाउ वी कैन save the uterus. Now, I'll give you a very brief description of various cases. This is case number one. This is a 59-year-old lady. You can see the hysteroscopy. You can see the movie. This patient is a 59-year-old lady. She came with postmenopausal bleeding. We did her ultrasound. There was a thick endometrium. So whenever thick endometrium is there, the first thing that comes to your mind is probably this is malignancy. Then we decided to do her hysteroscopy. And when the hysteroscopy was done, it was see and treat policy. We found that there was a polyp, a small polyp. And when this polyp was removed, the patient stopped bleeding. This was a benign polyp and her problem was solved. That means a simple procedure of hysteroscopy can save the uterus. Similarly, I'll show you this case. This is an interesting case. A 56-year-old lady, she is a known case of hypertension, obesity, and she is on aspirin as advised by physician. As you know, most of the patients nowadays are taking aspirin for various reasons. And you can see this hysteroscopy. There was a polyp, and also the endometrium was highly vascular. And you can see the vessels on the endometrium. You can see the red endometrium. It is angry red endometrium. So the vessels were seen on the endometrium, and endometrium was thin. Now, we talked to the physician and we asked them if we can stop the aspirin. The physician said there is no problem. We are doing giving her aspirin prophylactically. You can stop the aspirin. We stopped the aspirin and the patient stopped bleeding and the hysterectomy was saved or hysterectomy was avoided. So this is another example. Now a third case. She is a young lady. This lady came to me with the diagnosis of query vesicular mole. See, I have given you the ultrasound report which says query vesicular mole because there was a thick endometrium. We did her beta ECG, it was negative. She was 39-year-old lady with two kids and she was on the drug Sevista since last 2 years. Sevista is a centromine, which is a drug given for the treatment of AUB. She was on this drug for 2 years. I will tell you the importance of Sevista as we discuss further about this AUB. And when we did a hysteroscopy, we found that there was a thick endometrium and there was absolutely no other problem. Then we came to the conclusion that it is a Sevista or centromin which is causing her thick endometrium. We did her curettage, DNC was done, her report was normal. After 1 month, we subjected her to balloon therapy or thermal ablation. I will tell you about thermal ablation later on, and the patient's hysterectomy was avoided. So, three simple examples where you can see how the hysterectomy can be avoided in the patient of abnormal uterine bleeding. Now, as I told you, hysteroscopy is the gold standard. If you know how to do hysteroscopy, you will be able to diagnose so many things. It's like a see and treat policy. You can see the polyps. I have shown you three examples where hysteroscopy was done in all the three cases, and the patient got benefited because of the hysteroscopy. And this is the treatment which is very commonly done nowadays. We use hysteroscopy regularly, and at our Omega Hospital, we are using 2.9 millimeter Betochi hysteroscope, which is a small, very small hysteroscope, which gives you very good vision, and you are able to diagnose the condition and treat the condition in the same sitting. So it's like a see and treat policy. So a positive mind finds opportunity for everything, and a negative mind finds fault in everything. So if you want to find opportunity in everything, you should have a positive mind, and that is what is the saying. We come to the medical management of abnormal uterine bleeding, and there is a long list of drugs which are available for medical management. These drugs include ulipristal, which is used in fibroids, mifepristone, which is also used in fibroids, dynogest, which is used in endometriosis, centromine, which is also known as saheli. You know saheli, you must have heard the name saheli. Saheli is a drug which is used for contraception, but the same drug can be used for the treatment of AUB. Then we have leuprolide acetate injection, which is also called as leuprolide depot injection. And then we have Mirena, which is actually a LNG IUD or intrauterine device, which is used for the treatment of menorrhagia. So we have this cafeteria approach. We have so many drugs which are available. This we'll discuss one by one all the drugs. I'll tell you about the ulipristal first. Ulipristal is a drug which is used for the treatment of fibroid. I was lucky to that I was a principal investigator for the clinical trial of this drug, which was called as Pearl trial. This Pearl trial was very famous, and this was a trial which was done in 4 to 5 centers in India, very few centers in India, and our center was one of the centers. And we did many patients. It was a Pearl 1 trial, and this drug we tried to find out how it is working. So it works on the fibroids, reduces the size of fibroid. It works on the HPO axis and inhibits the ovulation, and works on the endometrium and makes the endometrium thin. This drug is available as 5 milligram and 10 milligram tablets. Ultimately, we found that 5 milligram is a good drug, and it was a very strict trial. We tried to include 30 patients. Out of 30, only 7 patients were recruited. And out of 7 patients, we found that 3 could be managed without surgery, and 2 patients had no response, and 2 had good surgical outcome with the reduction in the size of fibroids. So we found that overall this drug is good for the reduction of the fibroids and reducing the bleeding. Now there is a something called as the safety precautions or serious adverse effects. And SAEs are important because if you have SAEs, then it is a very dangerous situation. Luckily, at our center, there was no serious adverse effect, but this drug is known to cause hepatotoxicity. Friends, it is important that you should know this, that this drug is known to cause hepatotoxicity. And finally, there was a big controversy on this drug. And the controversy was so big that this drug was withdrawn from the market because of the hepatotoxicity, because there was a death reported with this drug. So now this drug is again available, but with a rider. Now people say that you can use this drug, but very carefully by doing liver function test every month. So most of the patients have stopped using this drug. Now the second drug, mifepristone. You must have heard the name of mifepristone. Mifepristone is the drug which is used for abortion. The same drug is an alternative to ulipristal. It is a cheap drug because it is one third of the cost of the ulipristal. It is available as 10 milligram and 25 milligram tablets, and we have started using this drug quite often in the patients with abnormal uterine bleeding and fibroids. There are many studies which say that it reduces the blood flow and reduces the size of the fibroid. And the biggest advantage was safety. It was much safer to use mifepristone as compared to ulipristal. But the only thing is, it is not totally free of side effects. 100% safety is not there. Still, there is a possibility of hepatotoxicity, and therefore you should do the liver function test. Then comes the third drug. So I have discussed about the ulipristal. It is not used nowadays, not a very good drug, but then mifepristone, which is okay. Third is Dynogest. Dynogest is the most popular drug nowadays. Why? Because it is cheap. It has got minimum side effects or no side effects. And the third, and the beauty of this drug is that it can be used for a long term of almost 5 years. Now, what are the conditions where the Dynogest is used? Endometriosis, where the patient has got adenomyosis, where the patient has got bleeding with pain. All these conditions, Dynogest works very well. And therefore, it is a drug of choice in the treatment of endometriosis and adenomyosis. And it is available as 2 milligram tablet to be taken once a day without break. And there are now clinical trials which say that you can give it up to 52 weeks. That means you can give it, and there are drug trials which are now coming that you can give it for almost 5 years. So the new drug trials say that you can give it for 5 years. So definitely you can give it for 1 year. That is for sure without any side effects, and that is the beauty of this drug. So this is the drug which is now becoming very popular. Then I have told you about centroman. Centroman is also called as Saheli. This Saheli is, you must have heard of this drug. This is a contraceptive drug. It is to be taken once or twice a week. Now, this is the drug which is used by many gynecologists for the treatment of abdominal bleeding. But a word of caution, I never use this drug. Why? Because I have an experience, which is a bad experience with this drug, that the endometrium becomes thick. The lining is thick, and I have shown you the third case. You remember the third case? I have shown you the third case where I have shown you how the endometrium becomes thick, and the radiologist gave the wrong diagnosis of vesicular mole because that radiologist thought that probably this is a vesicular mole. So endometrium becomes so thick. This is the side effect of centroman, and therefore centroman is not a very good drug. It can be given once or twice a week. There is one more injection which is available in the market, that is called as leuprolide or leupride depot injection. Leuprolide is a drug which is called as GnRH agonist. It suppresses the HPO axis, and by suppressing the HPO axis, it actually is responsible for reducing the size of fibroids, reducing the pain associated with endometriosis, and reducing the bleeding associated with AUB. So this is the drug which is used very commonly in abnormal uterine bleeding, fibroids, adenomyosis, and endometriosis. Now, the advantage of this drug, it is depot preparation. You can give it for once a month, that is 3.75 milligram, and 3 months depot preparation, 11.25 milligram. It is an intramuscular injection, but you cannot give it for long term. You can give it for 4 months or at the most 5 to 6 months. Second thing, this is the drug which is known to cause osteoporosis. This is a drug which is known to cause the side effects like menopause. So patient will have hot flushes, patient will have night sweats, and patient will have menopausal symptoms with this drug. And the most important thing is osteoporosis, and therefore this drug is also good for short term use but not good for long term use. So this is the drug which is good for long short term and not for long term use. Next is the Marina. You must have heard of Marina. What is Marina? Marina is intrauterine device. which is used for the treatment of menorrhagia associated with all these problems. It contains levonorgestrel, which is released very slowly over the period of 5 years in the dose of 20 microgram every 24 hours. So per day, 20 microgram of this LNG is released. And the advantage of this drug is it is for 5 years. So you put it and sure, forget it. That is the biggest advantage. So you have to put it, but it is like a copper tea. So some patients they are not very comfortable. Not they are very anxious. They say that मला copper tea suit होत नाही, मला copper tea चालत नाही, सर मला हे टाकू नका. पण this is the drug. रोज गोळ्या खाण्यापेक्षा कधी पण you put it in the uterus and it will work for 5 years. That is the advantage. So we try to convince the patient because you can actually avoid the hysterectomy with this Mirena. It is good for fibroids, it is good for adenomyosis, it is good for endometriosis, it is good for AUB, and it also gives you additional protection of contraception. So it is a contraceptive also, and that is the advantage. It makes the endometrium thin. See how the endometrial lining becomes thin when you put it, and the patient's menstruation is reduced. So either patient gets scanty menses or no menses at all. There is a procedure which is important, and you should know how to put this Mirena inside. I must tell you that sometimes you may require anesthesia because it is not very easy, but mostly it is done without anesthesia. As you can see here, this is the video how to put the Mirena inside. So you have to see the uterus cervical length, and then you have to advance the Mirena and put it inside. Open the flanks. So like this, you pull it and open the flanks. And after you open the flanks, you push it down again in the towards the fundus, and then pull the plunger so that the Mirena stays inside the uterus. Very rarely we may actually do it under anesthesia, but because if the patient is not able to tolerate the pain, you may have to give anesthesia, but usually it is done without anesthesia. As you can see, the bleeding becomes less with the Mirena and the pain also becomes less. But you cannot, there are some contraindications for this Mirena. You cannot give it if there is an infection. You cannot put it if there are patient is on anticoagulants. If the patient has got migraine because it leads to fluid retention and the patient may have migraine attack may increase or patient may have more headache and liver diseases, of course, you cannot give because it's a progesterone. Then there are some side effects which are also important. Patient may have pain. It may be difficult to insert it. As I told you, you may require anesthesia. The patient may have problem for 3 months, and this is an important point. This is a practical point. And if the patient comes to you with Mirena inside, she may be not be very happy for first 3 months. So you should remember, you should tell the patient that you should have some patience. Wait for some time. This Mirena will take some time for its action to start, and therefore, first 3 months, you may have some bleeding, some pain, discomfort, but tolerate it. And after 3 months, the patients are very happy, and then they say, "Thank you, doctor. तुम्ही आम्हाला थांबायला सांगितलं. We are happy. आपने हमको बोला कि आप रुक जाओ, लेकिन अब मेरे को अच्छा लग रहा है, and I am now happy." It may lead to perforation, spontaneous expulsion, and pigmentation. Spontaneous expulsion is also one more thing which you should know because this sometimes the bleeding is so heavy that Mirena may wash out, may come out along with the bleeding. This is something which you should know, and this may lead to pigmentation for a long period if you put the Mirena inside because it's a levonorgestrone, which is a progesterone. You may get pigmentation on the skin, and this pigmentation is sometimes very, not very patients are not very happy with this pigmentation. So you should keep this in mind that patient may get pigmentation because of Mirena. Now in our hospital, Omega Hospital, we have statistics. We we use it quite often. So last 6 months we have inserted 11 Mirena. Out of these 11, we required anesthesia in 2 cases. One patient it came out expulsion. After 3 months, there was a problem in almost 5 patients. And one thing which I would like to tell you is you can use various now. So we have discussed all these drugs till now. Mirena was the last drug which we have discussed. You can use some drugs in combination. How you can use it in combination, I'll tell you. As I told you, first 3 months, Mirena may take some time for its action to start. So what you can do is you can give Lupron injection. Lupron injection can be given for 3 months, and then you put the Mirena at the same time you give Lupron injection. Lupron injection will work for 3 months. Then you stop Lupron injection, Mirena will start functioning. This is how you can use your clinical acumen. You can use your clinical knowledge and provide relief and help to the patients. The patients are happy because of your expertise. Nowhere it is written that you can use combination of Mirena and Lupred, but you can try this. And I have tried this in couple of my patients. In three of my patients, as I discussed here, patient got dramatic relief of pain and bleeding when the combination was used. Why? Because sometimes the fibroids and adenomyosis, they give severe pain, and this pain is so difficult to tolerate and handle that the patients, they come, they are yelling, they are in agony, they are crying. And then in that situation, you, if you just help them by giving them a combination of Lupred along with the Mirena, the patient are definitely getting relief and they're happy. So I'll give you the markings now for all the drugs which we have till now discussed. This is my marking system because I have this experience of almost now 27 to 30 years where ulipristal is I have got side effects and therefore it's a problem of hepatotoxicity. It is costly also, and it is, I will give you 6 out of 10. Mifepristone is good, but I'll give 7 out of 10 because it is less toxic as compared to ulipristal. Danoist, I'm very happy with Danoist, but if it works very well. So here I'll give you 8 out of 10 marks. Centromine, I am not happy with centromine, so centromine I'll give 4 marks. Then Leupride, I am happy for short term, so 6 out of 10 marks. But Leupride, the problem is of menopausal side effects, as I have told you. It is good for fibroids and endometriosis. And last is levonorgestrel, which is good for fibroids, endometriosis, and AUB. The problem is only of expulsion and difficulty in putting the drug Mirena, and also the first 3 months of Mirena are sometimes problem. But it was initially almost 8,000 to 10,000 was the cost, but now the cost is reduced to I think 3,000 something. So it is quite cheap now, and it is long term. So I will give almost 8 marks to Mirena. So Mirena and Danoist are the two drugs which I am using in my day-to-day practice, and they are doing very good job. A man who masters patience masters everything, and this is what is important. This is very true in the medical management of ABB. You should have patience. If you have patience, then definitely these drugs are going to help you. Now some other treatment options which are available: uterine artery embolization. UAE is done by radiologist, where the embolization of the uterine artery is done and the blood supply to the that part is reduced. This is used mostly in case of fibroids, and this is very good treatment option which can work very well. But mind well, it should not be given if the patient is planning pregnancy. Now there are studies which say that UAE can be given even if the patient is trying to conceive, and it helps in the patient may conceive also, but there is a difficulty in conception if there is a uterine artery embolization done. Therefore, uterine artery embolization, it should be as far as possible avoided if the patient has not completed her family. Otherwise, for fibroids, uterine artery embolization is an excellent option. And a very big fibroid, if you do the embolization, the fibroid shrinks in size, the bleeding stops or bleeding becomes less, and the patient is happy, and the surgery can be avoided. So this is about uterine artery embolization. Then one new thing which is now available. It is available in Mumbai. It is available in metros. It is available, I think, in Lilavati Hospital also. It is called as MR guided. MR guided means MRI guided focused ultrasound surgery. MRGFUS. MRI is used for focusing the fibroid, and ultrasound waves are given to the fibroid. So this is the technique. This is the technique where you can see this is the fibroid, and this fibroid is actually destroyed with the help of ultrasound waves, and this is done under the guidance of MRI. So it is called as MR guided focused ultrasound, and this is what is done in nowadays to melt the fibroids or reduce the size of the fibroids, and the bleeding also becomes less. Now we come to the surgical options. Surgical but conservative option. So to be in 1%, you have to do what the 99% won't do. If you do something different, then patients will be happy with you. And two options which are available, which are called as conservative surgical managements, and these are TCRE, that is transcervical resection of endometrium, and thermal balloon ablation. So these are my two last points. I will take another. Archana, is it okay if I get give and take another 10 to 10,
Yes, sir.
12,
Yes,
12
sir.
minutes?
Yes,
Okay,
yes.
so last 10 to 12 minutes, I am coming to the last part of my uh, talk, that is surgical options. But these surgical options are also not hysterectomies. Remember, friends, it is not hysterectomy, it is a conservative surgical management. So, first is you should remember few things. Submucous fibroid, the fibroid which is inside the cavity of the uterus, can be removed with TCRE. TCRE is a hysteroscopic surgery where you can remove the submucous fibroid with the help of a resection of the endometrium. But otherwise, if there are big fibroids outside the uterus, or if the uterus is very big in size, or if there are ovarian tumors or ovarian cysts, in that situation, you cannot use these two treatment options, TCRE and balloon therapy or thermal ablation. So it can be used only in patients with normal uterus. So if the patient comes to you with abnormal uterine bleeding, there is no fibroid or there is no ovarian cyst, you can definitely give option of TCRE or balloon ablation. In case of fibroid like this is called a submucous fibroid, the fibroid which is inside the cavity of the uterus. You can use TCRE because TCRE will help you in removing the fibroid. Actually, this TCRE came from the concept of TURP. You know what is TURP? Transurethral resection of prostate. Prostate, in prostate आजकल हम लोग सब TURP करते हैं, है ना? तो TURP यूरोलॉजिस्ट ने चालू किया, और उसी यूरोलॉजिस्ट ने जिन्होंने TURP किया उन्होंने TCRE का भी ट्रीटमेंट चालू किया, where they use hysteroscope for resecting the endometrium, transcervical resection of endometrium. So endometrium was resected, it was removed, and as the endometrium was removed, the patient stopped bleeding. So it is very good for the medical management, and the patient will get relief. If the patient is not getting relief with the drugs, then you can do this. If you can do it, even if there is a fibroid, but fibroid has to be very small in size, and you should do this treatment only when the patient has completed the family. You can do this under short anesthesia also, but usually you ask the patient to come nil by mouth, and then you do it under spinal anesthesia or epidural anesthesia, which is the best anesthesia. So best anesthesia is spinal or epidural anesthesia. This is the instrument which is used, which is called as Bertocci hysteroscope, and this is the resectoscope which is used, and there is a loop which is used for removing the inner lining. As I told you, spinal anesthesia is preferred, epidural can also be given. General anesthesia is usually avoided. Why it is avoided, I'll tell you later on. But this is the procedure which is carried out under water. It is called as underwater procedure. So what is the medium which is used? The fluid which is used is either glycine or normal saline. Now, the best part is nowadays glycine is not used, because now the new instruments which are coming, they are bipolar instruments. And in bipolar instruments, saline can be used. And that is because the safety of saline is very high as compared to glycine. This is how the procedure is done. I'll show you the videos of this procedure. This is how the procedure is done. You have to, this is the loop which is used. With the help of a loop, you have to just remove the inner lining. And after removing the inner lining with the help of a loop, you can actually use this ball to do the coagulation. So see how जैसे फावड़ा चलाते हैं ना, उस तरीके से inner lining is removed with the help of a loop, and after removing the inner lining with the loop, you can use this balloon or this ball for actually coagulating the surface with the bleeding vessels. And this is how the procedure is done. Now, why we are using um, spinal anesthesia and not general anesthesia? Because the most dreadful complication, देखो सब अच्छे से चल रहा है, देखो अभी सब अच्छे से चल रहा है, we are happy, everything is fine, and what happens that everything is fine, and suddenly what happens? There can be a catastrophe, and this catastrophe is very dangerous. The patient may have fluid overload and pulmonary edema and pulmonary embolism. And this happens because of the fluid overload. And that is the biggest problem associated with this treatment. What is that called as? Fluid overload and pulmonary embolism. And to avoid this embolism, we use normal saline as a medium. It is good. And second thing which we do to avoid this embolism is we give spinal anesthesia to the patient, so that the patient is talking to you, she is conscious, because the first sign of fluid overload is disorientation. The patient starts talking irrelevantly, the patient gets disoriented, and then she goes into the fluid overload and pulmonary edema. So here, if you find that a patient is disoriented, immediately give Lasix to the patient, put the catheter, and stop the procedure. If you do not stop the procedure, patient may go into the pulmonary edema and patient may die immediately on table, and that is the most dreadful complication of this TCRE. As I told you, the patient will get relief. Patient will have amenorrhea, scanty periods, normal periods, or no improvement at all. But most of the patients they get relief. The only problem with this is the problem of complications. And we are also doing TCRA very commonly, but I personally prefer the next treatment, and that is thermal ablation. So to be successful, you don't need beautiful face and heroic body. What you need is skillful mind and ability to perform. So the last treatment option, which I am very happy with this procedure, is balloon ablation or thermal ablation. So TCRE was the first treatment option which was available, but people started realizing that TCRE can lead to the complications which are dreadful. So everybody was looking for the option which is safe. So safer option then came the balloon therapy. This balloon therapy, we have got this machine with us. We use this therapy in the patients of menorrhagia, in the patient which are very obese, very obese patients where you cannot do surgery, the patient where the uterus is normal but the endometrium is thick, and the patient who are having chronic diseases like heart disease, kidney disorders, and where the surgery is contraindicated. In all these situations, you can do thermal ablation. It is a very good procedure, but there are some contraindications. If the patient wants to conceive, if the family of the patient is not completed, you should not do this. If the patient has got latex allergy, you should not do, because the latex is no is a substance which is used for this balloon. So latex allergy, you cannot do this. And malignancy patients, you of course you cannot do this, and you can do this for only one cycle. So that is what is thermal ablation. We must do DNC before doing thermal ablation, because you have to rule out cancer. Malignancy ruled out, DNC done, then you do thermal ablation, and then it is the next point. As I told you, this is the procedure which can be done under short GA, but preferably in spinal anesthesia, and best is the epidural anesthesia. Why epidural anesthesia is best? Because these patients they get severe pain after the procedure, and this pain can be reduced by giving epidural anesthesia. Now, how to do this? This is a machine which is used. You can see this machine. This is the machine. This is a thermal balloon ablation machine. And we first do the PV examination. We dilate the uterus, and after dilating the uterus, we insert this balloon. So this is the balloon. You can see this is the tip of the balloon, which is made up of latex. And this balloon is inserted inside the cavity. And this balloon, after going inside, it is dilated, and it goes inside. It swells, and this balloon is now filled with the water, which is at temperature of 89 to 90 degrees. And under this 89 to 90 degrees of thermal ablation, the balloon ablation is done. See how it is done. This is the procedure. First, I have done the curettage. After doing the curettage, this is how the balloon is tested. After testing the balloon, the next step is to see this balloon. This is the balloon which is now taken. After taking this balloon, we are inserting this balloon inside the cavity of the uterus. See how it is inserted into the cavity of the uterus. After inserting this balloon inside the cavity of the uterus, you have to wait for heating time of 3 to 4 minutes and therapy time of 12 minutes. So the total timing which is required is 16 minutes. First 4 minutes it will heat the balloon, and after heating the balloon at 90 degrees, it will do the ablation of the endometrium. The charring of endometrium is done for the period of 12 minutes. And so ultimately 16 minutes of treatment is done, and the patient is ultimately getting the relief because of this. So this is how it is done. So you can see here the volume stabilization done, and this is the pressure which is used, and ultimately after 16 minutes this balloon is removed, and you can see there is a charring, and this balloon is responsible for charring the endometrium, and the endometrium is destroyed with the help of the heat or 90 degrees of temperature. Now, sometimes it may lead to thermal injury, but you have to be careful. Otherwise, the patient may have thermal injury. And the most important thing is the patient may have severe pain after the procedure. And therefore, as I told you, you can do epidural anesthesia. Sometimes patient has got nausea and vomiting. So if you give epidural anesthesia, then the patient gets relief. And the another complication which is important, and that's why I tell all my patients whenever I do this balloon therapy, I tell my patient that you will get discharge, vaginal discharge. और जैसे जलने के बाद कैसा सीरस डिस्चार्ज होता है ना, वैसे बर्न पेशेंट्स को जैसे सीरस डिस्चार्ज होता है, वैसे ही एंडोमेट्रियम में से सीरस डिस्चार्ज निकलता है. बिकॉज यू आर बर्निंग द एंडोमेट्रियम, यू आर चारिंग द एंडोमेट्रियम, there will be a discharge which is serous blood stain discharge which is coming for 1 month, and therefore you have to be careful and tell the patient that you may get discharge for 1 month. At Omega we did a study where we did this balloon therapy in 38 patients, and we found that there was amenorrhea in almost all the patients, in spotting in few patients, and hysterectomy was required in only one patient. So it is giving very good results. As I told you, this is how the patient percentage is there. 26% of the patient got severe pain, and 15% patient had discharge. But this can be treated very effectively if you counsel the patients properly. So 37 cases totally done. Most of the patients were obese patients, patients having medical disorders, patients having some kidney disorders, and in all these patients, we got very good results. And 29 patients, they were happy with amenorrhea. 5 patients had scanty menses. Only 2 patients had normal menses, and in only one patient, it failed and hysterectomy was required. So it was only one patient where hysterectomy was required. Otherwise, almost all patients they were happy and got the relief. I have done balloon therapy of many of my patients, and many of them they are doctors also. And one of my doctor friend, he jokingly says that Chaitanya, हर महिला का 2 बच्चे के होने के बाद बलून थेरेपी कर लेना चाहिए. That is what he says jokingly, because his wife is so happy with the balloon therapy, because the patient does not get menses. But the beauty of this treatment is that hormonal imbalance is not there. You are not touching the ovaries, you are not doing any surgery, so the patient will have good hormone levels. The patient will not get menopausal symptoms, but patient will get relief from the bleeding, and the patient is happy. So that is the beauty of this treatment. So if you just compare these two treatments, I must say that thermal ablation is better than TCRE. A TCRE does not work very well in young patients. If the patient is less than 43 years, it is does not work very well. But thermal ablation is also not very good in patients with fibroids, with a big uterus, or if the uterus is retroverted. Because if the uterus is retroverted, it is going backwards. The balloon may not be able to, char the endometrium completely, and therefore the patient may not get relief. Otherwise, thermal ablation is always preferred over the TCRE. So what we do at Omega, at our hospital, we usually do proper counseling of the patient, and we offer all the treatment options available. And we also suggest them की तुमच्या केसमध्ये हे चांगलं राहील, तुम्हारे केस में ये ज्यादा अच्छा रहेगा, एंड ये करके देखो. We do suggest them, but we ultimately let them decide, because they should be given that empowerment to decide what treatment they want. Also, we discuss with the gynecologist who has referred this patient, and also discuss with the patient. And we also see for the indications, like specific indications. Suppose the patient is having polyp, then in this patient TCRE is better, because if you are removing the polyp and then you are removing the endometrium also. Suppose the patient is very obese, then maybe thermal ablation is better. And we also discuss about the problem of thermal ablation and problems associated with the TCRE. And the TCRE is having serious complications which are not seen with the thermal ablation. So after discussing this, we give them cafeteria approach and let them decide. So I must tell you, friends, that although the success rate for treatment with heavy menstrual bleeding are not as high as the success rate of hysterectomy, because hysterectomy is like na rahega bas na bajegi basuri, but the patient satisfaction rates are surprisingly comparable. इंस्टेंट रिजल्ट तुमको नहीं मिलेंगे, इंस्टेंट रिजल्ट के पीछे रहोगे तो तुम खुश नहीं रहोगे, बट ultimately it gives you very good satisfaction to the patients. So ultimately what is important is you should have a cafeteria approach. You should have clear idea in your mind that what is the treatment option which is available for any given patient. You should discuss everything with the patient and her husband. You should assess the situation and just do it, because whenever you say I will try, you never do it. And Nike says just do it, and you if you just do it, then you will definitely get the results. So जो सफर की शुरुआत अच्छे से करते हैं, जो सफर की शुरुआत करते हैं, वो मंजिल को पार कर लेते हैं. एक बार चलने का हौसला रखिए, अच्छे इंसानों का तो रास्ते भी इंतजार करते हैं. And I must give you a very good and important take home message. that minimally invasive procedures that we have discussed today are here to stay. Patience, people say patience pays, but here, patience pays less in terms of money, but more in terms of satisfaction. And ultimately, at the end of the day, what you require is satisfaction, and patients are happy, so you are also happy. And that is what is the take home message. I am really thankful to you all for giving me this wonderful opportunity. Special thanks to Archana. And it was really very happy moment for me, and I really enjoyed interacting with you all. I think we should have now physical meetings, because now physical meetings are possible, and I think then one-to-one interactions will be much better. But of course, this is a good start. We have started with the Zoom platform, and soon we will meet in person, so that we all can have, heart to heart talk about how to go ahead with the management of abnormal uterine bleeding, and how to save the uterus, because that is our ultimate aim. Save the uterus is our mission. Save the uterus is our motto. Once again, thank you very much. Thank you.